Hi, everyone. Thanks for inviting me to be here. So I am also an informaticist and am the technical director for the HL7 Da Vinci project. And so I just wanted to briefly tell you about the project, its purpose, and then a few of our initiatives within the project to help address clinician burden. So HL7, as you're probably all familiar, is a standards organization and is really the home of the Fast Healthcare Interoperability Resources, or FHIR standard. And the goal with HL7 is to promote the use of the standard to improve interoperability. And within HL7, we have a number of what we call FHIR accelerators, which are communities of practice, in a sense, that come together to identify a number of important use cases that they want to address, and then collectively, with their time and their resources, drive the development of implementation guides and their implementation of the guides themselves in the industry to address those concerns. So we're really trying to address the challenge of these point-to-point integrations and to improve care through using FHIR. So we brought this community together, and it's a community of providers, payers, EHR vendors, deployment communities, and together we've identified a number of use cases that we have developed implementation guides around. And I lead work around the quality improvement and oversee the use cases in general. But for our conversation today, really want to focus on the ones on the bottom left around burden reduction. And that group of implementation guides is really focused on the prior authorization process and the challenges clinicians have of doing prior authorizations. So outside of the scope of this conversation is whether or not we should even have prior authorization. That's way above my pay grade. But recognizing that we have prior authorization, we want to make it easier for clinicians. On top of that, we have a number of other use cases that also reduce burden, but not specifically around prior authorization. We've developed implementation guides for collecting quality measure and reporting quality measure data, exchanging data between providers and payers about the patient's medical history, so that they reduce the need to reach out and get requests of information, and getting data, allowing clinicians to have a more complete set of data for decision making. And of note is we've created 10 implementation guides in 3 years, which, considering the throughput for a standards organization, that's pretty amazing. And a number of our guides have been identified in both the Patient Access API final rule, as well as some now proposed rules from CMS that have been pulled back into the regulatory process, and we're awaiting some additional guidance of whether or not we're going to do more commenting on them, or they're going to be released as final rules. So these are the guides. Really the dark colored ones are the ones that have been developed, validated, and published. So organizations can now pick them up and implement them, and as they implement them, we'll be maturing them and improving them. So really, what we want to do is focus on these first 3 sets of implementation guides, and we call them the burden reduction guides. And there are 3 guides. The first is coverage requirements discovery. The second is called documentation templates and rules. And the third is prior authorization support. And these are the 3 guides, along with a number of other Da Vinci guides that are referenced in regulatory documents. I'll call them that now. So the high level view of this, and the narrative I would give you, is you have a patient in your office and you want to order a given service, referral, item, or medication. And this medication is not a pharmacy benefit. Let's assume they're a medical benefit. So maybe one of the rheumatoid drugs or an oncology drug. Often the first question you ask is, does this patient need any prior authorization for this? And because you know the patient, but you don't necessarily know what the payer they have, and you certainly don't know what the payer coverage information is, you don't have that answer. So you probably have to order it, send it to your back office to find out if it gets rejected or whatever. And that causes a delay and certainly some burden on you and your office. So this first step uses FHIR and a technology called CDS hooks, which is part of FHIR, to embed this within your workflow. You're still in your EHR, and it launches a hook when you order the item, and it reaches out to a payer CDS service based on the patient's coverage information. And that payer, based on the patient's coverage and what you order, returns information to the provider as what we call a card. and that card says, no, you don't need prior authorization, great, you keep moving. Or it could say, yes, you need prior authorization or documentation, here's some information about it. It's helpful, but still not great. But the third thing the card can return is a link to what's called a Smart on Fire app. And if you're not familiar with Fire, I'm not going to cover it here, but there are plenty of resources on the web and with HL7 for learning more about Fire. But you can launch an app, a web-based app within the EHR. That app is authorized by the EHR and the payer, and it is authorized to extract information from the patient's record as Fire resources or data and data models. And the payer displays an app, and underneath that app are two components. One is a Fire questionnaire that asks all the information you need for documentation. But more importantly, along with that is a script called CQL, or Clinical Quality Language, that's married with that questionnaire and uses Fire APIs to pull the information that is already there and structured and available via Fire in the EHR. That's really important because that will reduce your burden of having to hunt and peck and collect information, because that information is there. So this is a good example of secondary use. It takes that information, such as allergies, conditions, medications. It can even pull any documents potentially, and then put them into that user interface of the Smart on Fire app. And then for things that don't have structured data or provide, or you need to enter some additional information, the provider can enter that information, and then they click done in the happy path. They click done, and what they collected was stored as a reference in the EHR and then forwarded to the payer, so that this third step, prior authorization support, it's forwarded to the payer, and that payer uses that Fire-based information and adjudicates that prior authorization request. And the goal would be for them to return in near real time a response, so that if you can get a prior authorization, then you haven't had to use a portal, you haven't had to delay the care delivery for the patient. And right now, because of HIPAA transaction rules, we do some transformation to 278 and 275 to support the HIPAA mandated, transactions. But ultimately, this could be done in a Fire-only approach and connect the payer and the provider much more closely. So again, we address three areas with this set of implementation guides. One is answering the question of whether or not you need a PA. Number two is giving you an application that gathers the information, and as much as possible, that's structured to complete the documentation. And then three is allow the provider to submit that information directly to the payer to get a near real-time or hopefully real-time adjudication. We recognize that that's the happy path. Some additional work we need to do is what happens when the ordering provider doesn't have all the information necessary that a servicing provider may have, such as when you're ordering, at least in the US, a wheelchair for a patient. There's additional information that a provider may not have, but may need support from a servicing provider. So we're going to build in some mechanisms for what we're calling delegation in order to again, streamline the process even more. We also know that sometimes there's information that's not available. Maybe you needed to do a lab and you didn't realize you had to do a lab. We want to be able to pause this process, maintain that collection of data, and then delegate to complete the lab, add any additional information, and then resume that session. And ideally, you're not going to have to use portals, and you're not have to monitor fax machines, and you'll be getting this within the context of delivering care. This is just one aspect of many aspects, actually, that we can use Fire to reduce burden. A couple of other approaches that we are doing in Da Vinci.
You have 1 minute.
1 minute. Okay, so we're working on quality measures. We know there's a lot of burden around collecting quality measure data. And so we have implementation guides around representing quality measures as Fire resources, and then gathering and reporting that data, or first of all, generating that data through delivering care, but also letting providers know what gaps are there so that they can close those gaps and then report them automatically. CMS and NCQA and the Joint Commission are fully on board with this approach, and CMS wants to convert all of their quality measures to digital in the future. And then really quickly, we want to show how payers have a lot of clinical data on patients, and we'll have more and more in the future. We want to make that data available to a provider who may not know the breadth and depth of care that's being provided outside of their clinic or organization. And so we have this payer data exchange to make that data available via FHIR into the EHR for those providers. And so all of these guides and a number of others are available to be picked up. We invite more and more clinicians and provider organizations to come participate in this, to work with us around implementation and to get yourselves up to speed on FHIR, because that's really going to be the underpinnings of how we exchange data and actually share it even in workflow in the future. It's in regulations already, and it's going to be in more regulations. But ultimately, I'm very bullish, and have been for many years, about the opportunities for using FHIR for improving care, and particularly for this conversation, reducing burden. So I'll pause there. Thank you.